Hello to the urologist everywhere, and welcome to one of our 5 minutes or less lectures. And in this one, we will speak about the BOTOX bladder injections. So to start with, there is some important information that you need to understand about the BOTOX. First, that it's a really potent neurotoxin and is mainly secreted by the gram-negative anaerobes bacterium Clostridium botulinum. There are 7 serotypes, but we are only interested in 2 of them, which is type A and type B. And most of the UK types are coming from the type A. For the toxin to start to act, it needs first to be activated, which usually happen by the clostridial protease enzyme, and these cleave the toxin into a lighter chain and a heavy chain. The lighter chain attached to the SV2 receptors in the presynaptic nerve terminals, and this by its role reduces the expression of the TBRV1 receptors, and also it causes proteolysis to the sypnipsomal associated protein SNAP25, and also inhibit part of the release of substance that's really helpful in the neurotransmission, like the substance P, glutamate, nerve growth factors, and the ATP. All of these effects actually cause an inhibition to the neurotransmission at the motor and sensory nerve terminals. Few important points that you need to know about the procedure itself. First, that it could happen under general anesthetic using a rigid cystoscopy, or it also could happen under local anesthetic using a flexible cystoscopy. The toxin itself comes into 2 doses, either 100 unit or 200 units vials. And the best practice is to dilute the 100 unit in 20 ml of saline, and to dilute the 200 into 30 ml of saline. And then you need to inject 1 ml in each injection site. So you need to divide your bladder into lines and dots, usually with a sparing of the trigon to avoid reflux. One of the most important papers that you may be asking about it, if you will be asking about any BOTOX question, which is a dignity study. It is a randomized controlled study between the 200 and the 300 units versus placebo in the neurogenic overactive bladder patients. So there is 2 groups of the patient. One of them is a multiple sclerosis patient, another spinal cord injuries. And the study did show that there is no difference at all between the 200 and the 300 units dose in these kind of patients. So there's the reason why now most of the people use just 200 units injections. A technical advice, that when you inject the BOTOX itself, you don't need to see that big submucosal plaster. You just need to see a small blip, and this means that most of the dose has been injected successfully in the muscles. When you see this plaster, it means that most of it has become submucosal, which ultimately will disperse. But the better is to see just a blip, not a big plaster. The outcomes that you need to be aware, and also the patient need to be aware of that usually the effects start after 7 days. The toxin itself degrades by 6 to 9 months, so it most probably will need redo after that time. 20% of the patient may end up with retention, and they will need a self-castration after that. And it doesn't work in almost 30% of the patients. So these points need to be really clear in your consenting forms. And beside that, you need to let them know about the risk of bleeding, infection, pain during the procedure. Sometimes the toxin may migrate and cause other paralytic neurotoxins effects. And that's it. I hope that this rabbit shot about the BOTOX was really helpful. Feel free to send any question on this email, and I will answer it once it's possible. And I'll be really grateful if you can also fill one of these feedback form by scanning the QR code that you've seen on the screen. And see you in a next talk. Best of wishes.